Hello and welcome. My name is Dr. Monica Peak, and I'm a general internist and health equity researcher. I'm also a member of the board of Physicians for Human Rights, and welcome to our program today. I'm delighted to be here with several colleagues, including Carla Torres, who serves as Senior Counsel for U.S. Human Rights at the Center for Reproductive Rights, with Ms. Nia Mitchell. She's a Vice President at Reproductive Health Impact. Dr. Michele Heisler, who's the Medical Director at Physicians for Human Rights, and Dr. Nicole Freehill, who's an obstetrician and gynecologist in New Orleans, Louisiana. So it has been 3 years, unbelievably, since Dobbs, and what has happened here in the United States? We know that there has been a consistent assault on women's reproductive freedoms across the United States, and that reflects not only an assault on women's rights, but as part of a broader assault on our democracy and bodily autonomy of all persons. And so this is really a perpetuation of marginalization of those who of those of us who are socially marginalized, that serve to exacerbate health inequities in our country. And so what I'd like for us to think about is, and talk about today, is how this particular situation affects not only women who are seeking abortion, the providers of abortion, but physicians in general. How this particular situation is not just a situation of abortion rights, but is part of a larger systemic issue around an assault for human rights for many people in this country. And so how can we use this as a case study of lessons learned as we begin to think about how we're going to be addressing these issues in other parts of our society? And so particularly as physicians, where we may be increasingly in positions of dual loyalty, where we have our obligation to our patients, but then we have a competing loyalty to legal systems that feel unfair, to our employer, et cetera. And so how do we manage those? And so really, like no other time in my life, it has become evident that it's time for us as physicians to really speak out. And so the goal of this webinar is to sort of underscore that importance. So I will start us off. The other thing I'd like to note is that this group has particular expertise and has co-authored 3 reports that we will also make sure that people who are observing this webinar have access to. The first of which is No One Could Say: Accessing Emergency Obstetrics Information as a Prospective Prenatal Patient in Post-Roe, Oklahoma. The second of which is Criminalized Care: How Louisiana's Abortion Bans Endanger Patients and Clinicians. And the last is, in clinicians' own words, How Abortion Bans Impede Emergency Medical Treatment for Pregnant Patients in Idaho. So in part 1 of this session, we're going to talk about the situation on the ground and what it means for pregnant patients' health and for clinicians' abilities to provide patient-centered, high-quality medical care. And so, Nia, I'm going to start with you, and just note for the audience that the United States has the highest maternal mortality rate of all high-income countries, at a rate of 32.9 deaths per 100 live births in 2021. And we know that states with abortion bans like Louisiana and Oklahoma continue to rank amongst the worst for states with maternal health outcomes. And so could you speak to the findings from the recent report and other information documented by Reproductive Health Impact about the trends in banned states regarding access to care, support for medical infrastructure, maternal health outcomes, and racial health disparities?
Thank you so much for your question, Dr. Peak. I'm so honored to join you and the other panelists for this very important conversation. So in 2023, RH Impact, along with Lift Louisiana, Physicians for Human Rights, and the Center for Reproductive Rights, conducted a fact-finding in the state of Louisiana to gauge the on-the-ground impacts of the abortion bans. Louisiana is one of several states that has a near total abortion ban, as well as legal and professional penalties for those providing abortion care of up to 15 years imprisonment and $200,000 in fines. The state has also has one of the highest maternal mortality rates in the nations, with Black women dying twice as often as white women, and more than a quarter of the state being designated a maternity care desert. Our research team conducted 43 in-depth interviews with clinicians and patients and held 2 focus groups with community-based organizations involved with reproductive health care access in the state. As a result, we collected stories from those providing and receiving care, as well as those advocating around this issue. Our research findings showed that Louisiana's abortion bans, narrow and ill-defined exceptions, create confusion, uncertainty, and fear for both pregnant patients and clinicians. Also, the threat of punitive measures against clinicians also undermines the quality of care they can deliver to pregnant patients. And it also erodes their ability to use their medical judgment to provide pregnant patients with the standard of care. As a result, pregnant patients are being delayed or denied abortion care in the state, even when they present with dangerous health complications or receive severe fetal diagnoses. Furthermore, the bans impact prenatal care, which is being delayed beyond the first trimester when miscarriage is more common. This leaves pregnant patients without critical information about their health and pregnancy in a state that already faces a maternal mortality crisis, as I stated. Unfortunately, the confusion and fear caused by the bans have led patients and clinicians to be unsure of what information they can ask for or provide, including whether a patient is experiencing a miscarriage, as well as referrals to abortion care outside of the state. And all of this undermines the patient-provider relationship. Also, those seeking an abortion must gather the necessary financial and material support needed to travel up, hundreds of miles to other states. And this is difficult for patients with limited resources and those living below the poverty line, people living in rural areas, as well as Black, Indigenous, and other people of color. Not only do these groups live in communities where there is limited access to healthcare, but many cannot afford to leave the state as others can. As one maternal fetal medicine specialist that participated in our fact finding shared, I've had so many patients that have ended up not terminating because they just can't figure out how to be gone for their homes for days, for 3 or 4 days, which is what it takes. They don't have the resources to be away from home, and that's really tragic. These patients also describe the stress of trying to save enough money for an abortion in case they got pregnant, and the difficulty of making out-of-state arrangements for transportation, housing, childcare, and the actual costs of an abortion within a particular time frame. Unfortunately, these patients are or will be forced to carry their pregnancies to term, which will only intensify their hardships. At the state level, bans are exacerbating what is already a broken state healthcare infrastructure. Clinicians in specialty hospitals noted an increase in patient referrals from rural hospitals, often for routine care that patients should be able to access sooner and nearer to their homes. Lastly, the bans have the potential to lead to a loss of healthcare providers, as some clinicians shared that they were reconsidering whether to continue practicing in the state, and medical students are weighing whether they want to pursue their residency in Louisiana. As I shared earlier, we conducted interviews and focus groups. So this was a qualitative study. And even though the stories we collected can't be generalized to everyone in the state, it really allowed us to paint a picture, a very disturbing picture of how harmful the impacts of abortion bans are, not just on patients, but also clinicians as well. And this is consistent with other research and evaluation that we've conducted that exposes the lack of access, quality, and continuity of maternal and reproductive health care in states, as well as the disproportionate impact on certain groups and communities. Thank you.
Thank you, Nia. That really highlights those very things that I was just talking about, as far as the challenges, not just for women in general, but how it disproportionately falls on certain kinds of communities, those that are more socially marginalized, and that it's not just affecting patients, but also clinicians. And so I'm going to ask now for Nicole, our practicing OBGYN, who is working in a state that currently bans abortions. If you could talk to us a little bit about your personal experience and tell us how the narrow and ill-defined medical exceptions have affected the types of care that are available to pregnant patients.
Yes, so thank you so much for allowing me to join this panel and speak about the problems that are going on in our state of Louisiana. There are definitely problems with the defined exceptions for what is allowed for an abortion. There is a list that has been put out, but the list is definitely not all encompassing, and there's always more that you are going to find that can happen with a patient or with a fetus to basically mean that she needs to have an abortion or should have that option. And it's very difficult to explain that to politicians. And so that has been a challenge. They do have a clause that has been put in that basically says there could be other things going on besides this list that has been put out, but that has been up to the discretion of each provider, each physician, each maternal fetal medicine specialist on if this condition or this problem should go into that exception list or should not. So that is definitely something that we need to continue working on moving forward. It needs to be much more broad and much more forgiving as far as if you have a physician that says this is threatening to the mother's life or a condition that is non-viable for a fetus, it just needs to be broadened and changed. We also have, as Nia had mentioned, a lot of fear, a lot of confusion regarding the abortion laws in general from a physician standpoint that has created an atmosphere where patients are not receiving care in a timely manner, where patients are being transferred to other facilities, where patients are being turned away for situations that they should not be. A lot of patients, unfortunately, are not being treated at the standard of care when they're actively having a miscarriage or need some other kind of urgent care during their pregnancy. And as already stated, and this is a point I always love to bring out, is the maternal mortality crisis that we have. And this is only going to make situation worse. And our marginalized populations are going to be the most greatly impacted. And that is just something that we need to work against as much as possible on all the different levels. I think that from a patient standpoint, it's just as confusing and just as fearful, because I've had many patients ask me, if I talk to you about an abortion, am I going to be arrested? If I seek out an abortion, is that going to be a federal offense? I mean, there's all kinds of questions that patients are asking because they don't understand the laws as they are written, just like physicians are not understanding the laws as they are written. So I think that the push to clarify laws and to educate our physicians, our providers, and our population is greatly needed and has been sorely missed as far as since Dobbs was, enacted and since Roe fell. I think that besides highlighting the maternal mortality crisis that is only inevitably going to worsen, the concern around what's next as far as what is coming next besides abortion. Is it contraception? Is it access to routine screening? Is it, you could open it up to a multitude of questions. And I think that that has both providers and patients very, very scared and very fearful. And I will tell you from a personal standpoint, even though I'm very lucky to have been very well educated on what the laws mean, what I can and cannot do, there are so many physicians that have not had that opportunity from either another physician or a lawyer who is very well read in these laws and can kind of navigate the nuances. But I think that this is going to create more of a problem moving downstream as far as laws getting in the way of patient care in the exam rooms and in emergency rooms. And that is something that there should be a clear delineation, in my opinion, that we cannot allow that to happen. And it's happening. And we need to find a way to backpedal that and not let it happen if at all possible.
So it sounds like one of the side effects that's happening is because there's so much uncertainty and fear, the physicians are foregoing care altogether, choosing not to engage in what might turn into a big mess and just sort of saying hands off and choosing not to engage in care. Can you talk a little bit about how this kind of environment has affected the patient-provider relationship, how you're able to make decisions with your patients, and how this sense of dual loyalty has affected you in making decisions that are in the best interest of your patients, knowing that you potentially have a conflict of interest in what may be best for you personally and legally.
Absolutely. So I think that I am lucky in the sense that I don't think that the changes have affected my ability to form a good relationship with my patients. I am not one of the physicians that is delaying care. I will see someone as soon as they know they're pregnant, as soon as they have any concerns. But there are definitely some physicians who are saying, I don't want to run the risk of this patient miscarrying, showing up and bleeding and hemorrhaging, and then the questions and the uncertainty of what can I do? Can I treat this patient? How can I treat this patient? So I think that that's a huge disservice to our patients for many reasons. I'm not going to get into them because there's so many. Prenatal care should be starting at the very beginning of pregnancy, if at all possible. That is the ideal way to have the best possible outcomes for both, the patient and for the fetus. I think that the dual loyalty is a very concerning aspect of all of this, because it is definitely the first time ever in my career that I am having to hesitate on what should I say or what should I recommend sometimes to patients as far as what is standard of care and what of all their options. We are legally allowed to still counsel patients on all of their options, including abortion. However, we're not allowed to coordinate or create, an appointment, do any of the direct transfer of care for a patient who chooses abortion. So it is still very difficult as far as the ethics of what my medical training says I should do and how I should be helping a patient with coordinating their care and getting them any resources I possibly can versus what legally is said that I can do. And it's a very fine line and a very difficult line sometimes to walk as far as helping patients but not putting myself in jeopardy. And it's something that I think a lot of physicians are choosing just not to engage at all, so as to protect themselves. And I understand where they're coming from. I mean, we've spent, all of us, years, doing all of our education, our training. A lot of us have families that rely on us. We can't be put in jail if at all possible. But that is a very big problem when it comes to our obligations and our ethical obligations to our patients. And that is a situation that I strongly believe any physician should not be placed in.
Absolutely. Thank you so much. So I'm going to turn now to Michele, who's had the opportunity to speak to many physicians as our medical director of Physicians for Human Rights. So across several reports that you've led in Louisiana and Oklahoma and Idaho post-Dobbs, you've spoken to countless clinicians experiencing firsthand how these bans have affected their day-to-day practices. So Michele, could you share some of the key findings about the impact of abortion bans on human rights and health of patients, as well as the ability for physicians to practice evidence-based care? And then just think about how this represents sort of a case study for how physicians in general, how this may affect us all. And what did you find particularly alarming about how these bans were written and implemented across the various states?
Yes, thank you. Thank you, Monica. Based on our interviews with, as you said, clinicians in a number of states with abortion bans, it would be hard to overstate just how much pregnancy care has been disrupted by the bans. Nearly every clinician we spoke with discussed ways that really the threat of being targeted for criminal prosecution had impaired the care that they felt able to provide to pregnant patients. And Nicole touched on a little bit of that, of feeling there's a target on your back because you want to do what's right for the patient, or having to provide care with one hand behind our backs, as one clinician said. Again, Nicole and Nia mentioned, but again, throughout these states, clinicians described multiple cases where they and colleagues felt that they had to delay or deny abortion care to pregnant patients. Again, that moment you have to wait. Are they close enough to death? Are they about to die? Is this okay? If many of these states do have the only exception is to save the life of the pregnant patient. So, those of us that are physicians, I think you, Monica, and Nicole know, you just, we become physicians not to just prevent death, but to promote health. So just a real attack on the integrity of medicine, the ethics of medicine. Clinicians and patients also described how the bans, and again, as Nicole mentioned, across these states, a lot of reproductive health care providers are actually delaying care. They're waiting until the second trimester because they don't want to see patients during that period when miscarriage is so common, with really serious effects for those who really do need to start care early in the first trimester. Again, and I will say, we've talked about dual loyalty, but really what's this caused is incredible moral injury, really the moral anguish that you're not being able to offer abortion care to patients who, and many patients, we heard stories of, patients that are at high risk of dying or having a bad health outcome, but didn't quite meet the cutoff. So again, just one example, which, also, you think about oncologists who, have to question whether they can give chemotherapy, or cardiologists who recognize that their patients have severe heart conditions. There was one case where they said, we had to keep maximizing medical management, someone who had very serious cardiac complications. And as this one doctor said, what if she doesn't want to wait that long because she could have a heart attack and die? At what point, again, at what point can you act? How many cardiac medications have to fail? And again, just the themes across the states of where patients would go to one small community hospital and be referred either to specialty hospitals within the state, or, as in the case of Idaho, actually airlifted to other states, which again, letting the complications get even more severe, often in many cases, because insurance doesn't cover that. Then the patient has thousands and thousands of bills from not getting care in their own state. So, those are the key themes. I will also mention, our research did focus on really keeping within the exceptions. Okay, you're trying to follow the laws, you're trying to follow the allowable, narrow, ill-defined exceptions. But I will say that clinicians did express anguish also about their patients, especially their patients without resources, who wanted to terminate their pregnancies, but really were unable to marshal the resources. Again, rich, well-off patients are going to do what's necessary. They're going to travel to another state. They're going to, if necessary, travel to another country. But again, that sense of abandoning their patients who just didn't have the resources, even if they were facing really difficult situations and really, really did not want to have another child. But clinicians also felt they were abandoning their patients with resources who were leaving the state with abortions, for abortions. One physician said, as a physician, it makes me feel horrible. I can't take care of them, and it is my patient. It's just horrible because my group has always finished the care of these patients and taking care of them through everything, no matter what. So again, moral injury, a sense of letting their patients down, not just not being able to provide high quality care, but not being there for their patients at every step of the way. So those are key themes throughout these states, and I'll end there.
Yeah. What's really interesting is this idea of a physician's conscience being coming into play. And I think that for so many of us who are listening to the national narrative, conscience has been used as a way to not be forced to provide, abortion services, which no one is ever being forced to do so. But what we're seeing is that a lot of physicians' conscious and their sense of moral injury is happening when they're not able to practice the medicine that we've been trained to do, as far as the full range of healthcare, and sensing that we're abandoning our patients and not being able to, do no harm. And so that, I think, is really insightful, is very powerful. And so thank you for that. I want to transition now to our legal expert, Carla, because physicians are feeling this way because of the different laws that are in place, because of the imposition of our legal system into our healthcare system and into the lives of and decision-making between patients and their physicians. And so since the Dobbs decision, so there's now a patchwork of different laws on the books across the country, including in some states where there's overlapping and sometimes contradictory bans. So can you first explain from a legal perspective how these bans violate human rights? And then at the federal level, what protections exist for clinicians when providing emergency medical care, and then how might these be at risk? And so Michele talked a little bit about sort of waiting until, you know, the life of the mother may be in danger. And so what is she talking about when she was saying that, and how might the federal laws be sort of protecting physicians for this kind of care?
Sure, thank you so much. So the U.S. has ratified 3 international human rights treaties that recognize and protect sexual and reproductive health and rights. And those are the International Covenant on Civil and Political Rights, the International Convention on the Elimination of All Forms of Racial Discrimination, and the Convention Against Torture. Having ratified these, the U.S. is obligated to respect, protect, and fulfill the rights that are enshrined in them. And that means that it cannot take actions that violate a person's human rights, including by creating barriers to exercising them, and that it must proactively create an environment that enables their human rights. While the federal government is ultimately responsible for reporting to human rights treaty monitoring bodies about how the U.S. is meeting these obligations, state and local governments play a critical role in ensuring that the U.S. fulfills its international human rights commitments. And what we found in our documentation work in Oklahoma and in Louisiana is that the bans disregard the U.S.'s binding legal obligations and violate a constellation of human rights that protect reproductive health and autonomy, including the rights to life, health, equality and non-discrimination, information, privacy, and the right to be free from torture and other cruel, inhuman, or degrading treatment. And some of the ways in which these bans do that is by endangering the life and health of pregnant patients, by delaying or denying time-sensitive care, and forcing pregnant patients to either continue their pregnancy or, as Nia was mentioning and Michele echoed, travel long distances to access care in states where abortion is legally protected, noting that many of them are unable to surmount the barriers to care that exist and may miss the window of time to obtain abortion care altogether. The bans also perpetuate inequality and discrimination by disproportionately impacting communities who already face discrimination in accessing healthcare. And that includes Black, Indigenous, and other people of color, people living in rural areas, young people, and people living on low incomes. And finally, subjecting pregnant Louisianans to physical and mental health risks that they would otherwise not experience if abortion was legal and accessible in the state, as it had been previous to the Dobbs ruling, or at least more accessible previous to the Dobbs ruling in 2022. And to your question about the federal protections that exist for clinicians when providing emergency medical care and how they may be at risk. So I'll touch on 2 federal protections. The first is HIPAA, the Health Information Portability and Accountability Act, HIPAA creates requirements for the use, disclosure, and protection of personal health information by health plans and healthcare providers. And that includes information related to abortion and other sexual and reproductive health care. The second, which has been in the news very much in the recent years, is the Emergency Medical Treatment and Labor Act, also known as EMTALA. EMTALA was enacted in 1986, almost 40 years ago, to ensure public access to emergency medical treatment, regardless of a person's ability to pay for the care that they receive. EMTALA provides rights to any person who presents at a hospital emergency room in a Medicare participating hospital and requests treatment by requiring hospitals to provide them with appropriate medical care. And because abortion care is indicated as stabilizing treatment in some cases, state abortion bans conflict with this federal protection and leave emergency care physicians in a really difficult position of, as you were mentioning, this dual loyalty of being beholden to a legal system, but also ethically beholden to provide standard of care to their patients. And of course, under EMTALA, providing stabilizing care, which includes abortion care. Post-Dobbs, HHS issued guidance clarifying that EMTALA preempts state bans. Abortion opponents and the state of Texas sued to prevent the guidance from taking effect in Texas. And in January of this year, a federal appeals court sided with Texas. In another lawsuit, the DOJ sued Idaho, arguing that its near-total abortion ban violates EMTALA. And while a lower court agreed with the DOJ in August of 2022 and blocked the ban as it applies to patients who fall under EMTALA, in January of this year, the U.S. Supreme Court reinstated the abortion ban. SCOTUS heard these cases just this session and will issue a decision this month, in fact. And until we get that decision, Idaho and Texas hospitals are not obligated to provide abortions to stabilize pregnant people who present at emergency rooms at eligible hospitals. And the Supreme Court's ultimate ruling, of course, could have implications for pregnant people and healthcare physicians nationwide.
Thank you so much. So I definitely am familiar with EMTALA because a lot of the physicians who worked to get that passed were based here in Chicago. And so shout out to all of those physicians, many of whom are still practicing medicine today. So we're going to move on to part 2, which is what can physicians do in our roles as individuals, as providers, as citizens, and within our institutions to advocate for clear guidance, for better standards of care, for our patients in general. And so, Carla, I'm going to come right back to you, sort of continue our conversation about EMTALA and some of these other things. How can physicians support these efforts to change law and policy at the state and national level? And then what other initiatives is the reproductive health community pursuing?
Thank you so much for that question. Well, so one way that they can support these efforts is by acting as plaintiffs in litigation. So one thing that the center has done is filed lawsuits and complaints in several states on behalf of women who were denied abortion care despite facing severe and dangerous pregnancy complications. And in those same lawsuits, we represented physicians who are essentially unable to provide the medically necessary abortion care that patients need because of harsh criminal, financial, and professional penalties they face. The litigation that we have filed is really seeking to clarify medical exceptions to states' extreme abortion bans so that pregnant people in dire situations can receive the care that they need and avoid risks to their health, lives, and future fertility in some instances, and so that doctors can use their best medical judgment to treat their patients without fear of reprisal. Physicians can also join efforts to advocate for legal and policy changes in their state or nationally by, among other things, testifying in support of laws that repeal abortion bans or that would establish strong legal protections for reproductive rights, including access to abortion. Healthcare providers play an important role in educating lawmakers and the public about the harms that these bans are causing, including to the everyday practice of medicine. So speaking up is really critical. And in terms of what other initiatives we're seeing in the reproductive health community to sort of shore up support for reproductive autonomy, including abortion access, I'll speak of 2. One is voter-initiated proposed state constitutional amendments. You may have read about these or seen votes. So within 6 months of the Dobbs decision, voters affirmed abortion rights in all 6 states where abortion was on the ballot, approving reproductive freedom constitutional amendments in California, Michigan, and Vermont, and then rejecting measures that would have restricted abortion in Kansas, Kentucky, and Montana. And then in November of last year, Ohio became the 7th state to vote to enshrine abortion rights in its state constitution. And this year, we will see similar voter-initiated constitutional amendments voted on in Florida and Colorado. And the other is interstate shield bills. These are laws that are passed in states where abortion is legal to protect providers and helpers from criminal and civil consequences in states where abortion is illegal. Some of the protections that we've seen is, denying bringing healthcare providers in a state where abortion remains legal to a state where it is illegal and they're facing criminal or civil penalties, protections around information. And since Dobbs in June 2022, we've seen 18 interstate shield bills enacted. And I'll note that the majority of these have extended their protections not only to abortion care, but also to fertility and transgender healthcare providers, because we see, we know that the end goal for anti-abortion advocates and lawmakers is not eliminating or really prohibiting access to abortion, but also other forms of reproductive healthcare services like fertility care and transgender healthcare.
Excellent. Thank you so much. One just follow-up question. If someone wanted to be able to testify, how would they get involved and who would they call?
Sure. Well, so in the case of Louisiana, I'll speak for one of our partners who isn't on the webinar today, at Lift Louisiana. I think reaching out to organizations that are doing the work every session, going to the state capitol to engage with lawmakers and to educate them is really one of the ways in which you can get involved. Is look out for the community-based organizations or a national organization that is involved in this work and offer to provide testimony. A lot of lawmakers are persuaded most by people who have been directly impacted. And so I think if you have been directly impacted, as many people have, including physicians, and feel emboldened and want to share that impact with lawmakers, reach out to organizations who are doing the day-to-day work at the state capitals to try and either push back against abortion bans or limits on abortion, or to strengthen abortion protections in their state.
Excellent.
Monica, one thing I would add is a number of our PHR clinicians who are involved with medical school asylum clinics, of where they provide medical legal documentation of psychological and physical harms that people faced who are fleeing persecution in their own home countries. We have several of our leading clinicians, one a psychiatrist and then another physician, who are working with legal groups to basically do medical assessments to show the psychological and largely psychological, in some cases physical harms that individuals who are denied abortion are facing. So they're actually using their clinical skills as psychiatrists. The other one is an OB-GYN. To document those harms. So I think we may find more cases where people are going to court to say, look, the state is inflicting significant psychological and physical harm on me from denying this right to abortion care.
That is a perfect segue for me to continue, Michele, asking questions about the work of PHR, because PHR is sort of known for documenting instances of dual loyalty, speaking out to support clinicians. They're being coerced to be complicit in human rights violations and things that harm the health of their patients. And so what kind of larger lessons learned have we has this organization, and have we learned sort of nationally and globally about this work that we can apply to supporting physicians facing this current dual loyalty situation and the others that we know are sort of coming down the pike in this country? And so I think that is a great one, because there's so many domestic physicians here in this country who've been doing the work of asylum cases. And so applying that same skill set, that same sort of paradigm, but expanding it. What else do we know from other lessons in PHR that we can apply to this paradigm?
Yes. And as you said, PHR has worked to investigate and to change many types of dual loyalty situations that clinicians and other health workers face. And, throughout history, powerful state actors have mandated clinicians to betray their professional obligations. And again, those obligations to center the health of their patients. States have coerced clinicians to participate in or support torture, withhold medical care from some individuals and groups, assist in executions, participate in research studies based on non-consensual medical experimentation, forcibly fed hunger strikers, among other human rights and health harming actions. Just in the area of sexual and reproductive health care, as we all know, a terrible history in our country and other countries where clinicians have been coerced to participate in forced sterilization, forced abortion, forced contraception, forced pregnancy, denial of contraception, and mandatory reporting of pregnant people suspected of substance abuse. And we need to be clear that these state actions that prevent clinicians from fulfilling their professional duties represent an attack on medicine, and they represent an attack on healthcare workers. And that's another area that PHR has focused on: attacks on healthcare, attacks on healthcare workers. We haven't talked about this today, but it's also important to note the increase in physical violence against U.S. and sexual and reproductive health providers. In 2022, there was a 20% increase in death threats and a 229% increase in stalking incidents of reproductive health care providers compared to 2021. So such attacks on the work and integrity of healthcare providers really represent a threat to all clinicians, regardless of our field or specialty, as much as they represent a threat to the health and human rights of all our patients. Just a couple of key lessons from PHR's work on prior work on dual loyalty. For example, our work in the case where psychologists and psychiatrists were coerced to participate in torture in Guantanamo. Also whistleblowers who were decrying substandard medical care and ill treatment in immigration detention centers and prisons. So first, medical and other professional associations are critically important to mobilize for advocacy efforts. So again, for those of you that are members of professional organizations, it's really important to work with your professional associations at the national, but especially at the state and local levels. And again, in the case of torture, the American Psychiatric Association, the American Psychological Association really played an important role in protecting their members from being coerced to participate in torture. And second, it's so important to mobilize and harness the voices and the moral authority of clinicians in all specialties. We can tell our stories, we can tell the stories of our patients who have been affected by laws criminalizing abortion, as well as telling the stories of patients that have benefited from laws in states that do protect the right to abortion care. Third, again, as Carla just said, it's so important that we engage in advocacy at our state level and to advocate for greater protections for clinicians and for patients at the federal level, while we also work to end laws creating the current dual loyalty crisis. We have to fight against dual loyalty situations, and we all have to fight against attacks on healthcare and on our patients.
Yes, excellent. There's been such a rise of violence in so many arenas that has been just sort of accepted. And so we have to push back against that against police brutality, against healthcare workers, against, so many different things. And so all of these are not isolated. These are all connected and how they're related. And so Nia, I'm going to come back to you in thinking about, again, how these are larger things in society, but how they disproportionately fall on those of us who are the most vulnerable, those of us who have the least resources or the least social power to sort of push back against that, and how it manifests in health disparities. We already know about the large chasm in Black maternal morbidity and mortality in this country, and how these laws are just going to be exacerbating that. We've also heard from Nicole about how many physicians are choosing to just sort of say, I'm not going to engage in that because I'm just afraid. And so can you talk about areas where physicians are continuing to practice, and many of them are sort of leaving, for those patients that are still there? What and how are they accessing the care that they need? And how can medical professionals that are there try and prioritize resources to support these communities under these existing bans? What are the sort of immediate priority areas for action and advocacy along with healthcare delivery?
Thank you so much for the question. So I'll begin by talking about the fact that communities, you know, and despite the fact that certain communities and groups are disproportionately impacted by these types of health inequities and healthcare deserts. But you still have people and organizations that have responded to and resisted, you know, our inability to receive healthcare, as well as these types of challenges and attacks. And even if it was done with little resources or while simultaneously addressing other types of health issues, whether that, like you stated, about the maternal mortality crisis or sterilization abuse, or issues such as affordable housing, equitable education, and, you know, a living wage. And so our part of our research findings described not just how community-based organizations, but also how physicians and just everyday people are working to get pregnant patients and their families, particularly those living below the poverty line, the information, financial assistance, and support that they need to self-manage abortions, as well as connecting them with agencies outside of the state for care. They're working to change policy, you know, as Carla had mentioned, as well as protecting themselves and others doing this work. In Louisiana, you know, this involves organizations such as Lift Louisiana was mentioned. You have Louisiana Abortion Fund, Women with a Vision, and a number of groups that are doing this work on the ground in communities at the state capitol, and have a plethora of like online resources that are available for patients. And the same is true in other states that have severely restricted or banned abortion. And so we encourage medical professionals, hospitals, and professional associations to get to know, uplift, partner with, give to, or even volunteer with these types of organizations supporting communities. Additionally, the information and resources that they provide can be shared with patients and their families. And, you know, this was consistent with our research findings. Community-based organizations describe wanting more connections with healthcare providers, not just in their state, but also outside of their state, because they are supporting and providing resources to patients to receive care in other states. And in terms of like the individual interviews we conducted, community members shared that they still wanted, and this isn't really directed just towards physicians. It could be the state health department or a number of other entities, but there's a need for more hospitals, birth centers, healthcare providers, and community health workers in these neighborhoods. They wanted more unbiased mental health support for pregnant people who are struggling or unable to get the prenatal or abortion care that they needed, as well as those information and resources about how to access abortion inside or outside the state, as well as access to sexual health education and preventative care. So contraception and Plan B came up a lot. And so I'll stop right there because I would, some of the recommendations I think have already been shared by the other panelists, but, you know, I would just hope that medical professionals and hospitals and those professional associations would connect with community and plug in. And as I stated, some already are. So,
That's
thank you.
excellent. Yes, it's always so important to remember that so many people are interested in the health and well-being of Black women, of you know, other women who really need these services, not only clinicians. And so to remember that there are other organizations that are out there. Nicole, do you have, as a practicing clinician in a banned state, anything to add to that? Anything that you personally as a clinician have found helpful when trying to help your patients navigate resources?
Absolutely. I think that from a standpoint of patients, I think that it's very important for physicians to share any resources that they know of, whether it's a local resource, a national resource, a state resource. There are a lot of resources, and I urge any physicians and any provider to educate themselves on what resources are out there, because as soon as you start looking, it's like Pandora's box. You can just find so much, which is great. I think from a standpoint of physicians trying to do what they can and advocate in any way that they can, one thing that I share on my own advocacy journey is that advocacy is many things. It is going to the Capitol and testifying. It is working with local organizations. It can be as simple and straightforward as helping your patient get their next appointment with the physician that they need. It can be as simple as making sure that they have resources to help them with getting transportation to a visit. I mean, you can advocate on such small but yet very meaningful levels, and there's all of these different levels you can advocate all the way up to a national voice. So I don't want physicians to feel like you have to be working with a huge state organization, a national organization. I think that's very important. But I think that anyone who's interested just needs to take the first step and just start an advocacy journey and see where it leads you. I definitely urge people to reach out to their local organizations. Lift Louisiana was instrumental in helping me start my advocacy journey and grow in my advocacy journey so far. And I think that that is a testament to the power that they have and the amount of resources and the amount of dedication that organizations like that are giving to not only this issue and this cause, but also many others. Oh, you're on mute.
Thank you so much. And so we're moving now into our last part of the session, which is just following up and having just a few questions that are sort of global for the group. One of the things that I know that we have touched on in a couple of different ways is the importance of this not being something that's only for physicians that are thinking about abortive care, and that how, many subspecialists, primary care physicians, their lives interact with women who are trying to prevent pregnancy, women who, because they're, undergoing chemotherapy, they're on highly toxic or teratogenic, medications, women who become pregnant unintentionally, but they themselves are carrying, are high risk because of their high disease burden and, put themselves at, health risks. And so there's so many other providers who are caring for women who are invested in their health, not only OBGYNs. And so how do we help expand the network of physicians to make sure that everyone has the access to, or the compelling mission right now to be able to join this this sort of these efforts? What are our suggestions? And maybe I'll start with Michele. And then, let's start with Michele.
Yeah, and again, I think others have really given wonderful specific ways to get involved. I would say that I think one important first step is for all of us, especially those of us who are clinicians, to understand and educate ourselves about the links between the issue of full access to abortion care and other areas of health. I mean, I'm in my clinical area, as Monica knows, and in much of my research, I focus on diabetes and helping people with diabetes. So, thinking about, my patients, the young women patients who absolutely would have severe health outcomes if they can't get early prenatal care because other physicians are afraid of providing early prenatal care. A strong focus of this panel has been just the ways that these abortion bans, the criminalization of abortion, is a health equity issue and impacts a wide range of health issues and human rights. I mean, there's a lot of focus on, structural determinants of health, of how policies and laws disproportionately harm low-income individuals, often communities of color. And I think it's really important for us to really think through and act and show the links between how important it is for overall health and well-being to have access to the full range of sexual and reproductive health care. And again, making those links between people who don't have good access to healthcare, don't have good access to contraception, don't have good access to just a range of health services, and then are also now further harmed by not being able to have access to abortion care. So I think that would be one thing, is that, you know, I'm a general internist. This absolutely impacts, you know, my patients. And if I care about my patients who have severe cardiomyopathies, you know, my patients who have comorbid conditions, my completely healthy patients who, you know, very likely could face a premature rupture of membranes, and also just that I want to promote their health and well-being. So I think that's one way. And I think it's also important that we explore the links between this and other assaults on democracy, on voting. Certainly, we all need to go out and vote. I think we all need to find ways that we can engage in advocacy, because it is interconnected. You know, this is not a surprise that the same states that are gerrymandering and restricting, you know, trying to prevent people from voting, and, you know, now, you know, restricting, you know, not expanding Medicaid, you know, cutting Medicaid, so that low-income people don't have access to healthcare. So these are very interconnected, and they affect really all of our patients, and it affects, you know, the work that all of us are trying to do to promote health, to promote the human rights of our patients and their overall well-being.
Thank you so much. And that leads me to think about our work with medical organizations. And all of us belong to some sort of national organization, be it the Society for General Internal Medicine or ACOG or something. And we could also work with those organizations, even if that organization isn't primarily about abortive care, and try and have them make position statements or become involved in some of the advocacy work. Anyone want to?
Absolutely. And you know, the Association of the American Association, excuse me, the American Medical Association has been absolutely at the forefront of this. And that is a medical association that encompasses, you know, all areas of medicine, at least nursing, the American Nursing Association. I mean, this really is an area that pretty much all the medical associations have taken a strong stance. And we need to support the state and local chapters of those national associations to also be, to feel that they have the support of their members to take strong stances.
And so I wanted to ask, I know that some of the studies and sort of lived experience on the ground has been that some of the clinicians that are doing this work have not had as much support in the states from their state level organizations as they would from the same organizations at the federal or national level. And so what can we do to support, you know, the dwindling number of providers in those areas who may not be getting the same kind of support from their local organizations?
So I would say get involved and educate yourself on who is on the state board, who is running your organization at a local or state level. And if you're not finding that you're seeing support or help or guidance in any way, the best way to make those changes is to get involved. You know, that is something that is actively being worked on in Louisiana, I can say from an ACOG standpoint. And I think that it is going to greatly help physicians moving forward once Louisiana ACOG is more active and more vocal and is on that path. So I think that getting involved and helping out in any way you can, even if it's on a small level, even if it's just attending a meeting that the state organization is having that you've never gone to before. I also think that it's very important to realize from an outside of an OBGYN standpoint, if, as it has been pointed out, this encompasses all of our all specialties. This encompasses every area of medicine. No matter what kind of a physician you are, you are going to have patients that are going to be impacted by this. And this attack on reproductive health rights in general is opening the door to what else could possibly be attacked, what else could possibly be limited. And if you think that your specialty is not next, you might be wrong. So getting involved and speaking out and educating yourself in any way you can is critically important.
And so that's one of the questions that I wanted to bring up as we're wrapping up. What do we see on the agenda? I think we all sort of know that contraception, transgender care certainly is actively under attack. What other things are we seeing in the future as the Supreme Court, as other legislative bodies are getting more and more involved in trying to have physicians stray away from evidence-based medicine and practice medicine in a way that reflects politics more than it does what we know to be standard of care and good care.
I would note that since the Dobbs decision in 2022, we've definitely seen anti-abortion advocates and legislators become emboldened and target, as you say, not only abortion, but other types of care as well. You know, you mentioned contraception. I talked about EMTALA, or access to abortion in emergency rooms. There was also just the recent ruling on the FDA's authority to authorize mifepristone, so medication abortion. And we're already seeing, and knew this would come, but I think we will continue to see attacks on access to fertility care. You know, we saw the Alabama Supreme Court ruling in February that found that cryopreserved IVF embryos are quote unquote unborn children. The push for personhood has been a mainstay of anti-abortion advocates and lawmakers for many, many years. And as I mentioned at the top of our webinar, their end goal has not been only to eliminate or prohibit abortion, but to undermine reproductive autonomy and freedom more broadly. And that includes access to fertility care, which is so critical for so many of us to grow or build our families. And what we've been hearing is Republicans saying that they support access to fertility care, but also, you know, supporting legislation or espousing that life begins at fertilization. And those two are diametrically opposed or incompatible stances, and calling for fertility care for married couples. And so therefore really identifying who they believe or who they want to have access to this kind of care. And also speaking about so-called ethical fertility care, which is really would undermine the standard of care that is currently provided in fertility care, where IVF has really been you know, honed over many years to try and be as efficient, as effective, as patient-centered as possible to increase the chances that fertility care leads to a pregnancy, that leads to a live birth. And the way that a lot of lawmakers and anti-abortion advocates are speaking and now targeting access to fertility care is very concerning. And, you know, we can see other forms of reproductive healthcare services also coming under some similar attacks.
Absolutely. Well, I think we're going to have to end it there. I want to thank you all so much for your time and your energy, for your passion in doing this work. And fighting for the rights of women everywhere and upholding our democracy. I hope that everyone who has been watching has learned something and has been motivated to get out and join us in this fight. And I hope everyone has a great evening. I'll let everyone have maybe 2 seconds for a final thought. Carla?
Sure, just to say that I hope that the folks who are watching this will turn to the reports that Dr. Peak mentioned at the top of this webinar, and really just learn about all of the documentation that we did over many months in Oklahoma, Louisiana, and Idaho, and then reach out to your local organizations if you do, like Dr. Freehill mentioned, want to get involved and do advocacy work of that kind, and really, you know, get involved, because this absolutely impacts you. And you have a very critical role to play.
Great. Nicole?
Thank you. Yes. So I would say educate yourself as much as you can about all of the various aspects of these restrictions and these laws and these bans, and educate your patients as best you can. Reach out. I have physicians reach out to me on a very regular basis, asking questions, wanting to learn more, do more, and that we just need to keep that going. And I think that advocate in any way you possibly can, even if it's on a very small level or a very big level. Everything's important.
Absolutely. Lifelong learning. That's what doctoring is. Nia.
Yeah, I would just emphasize the interconnectedness of this struggle to other struggles that are happening. And also to reiterate what Dr. Freehill stated in terms of, responding or plugging in whatever way you feel comfortable, whether that is, offering more support and resources to your patients or getting involved with a local or even national organization or serving on a board. And so I would just end with that, and thank you for your time.
Thank you so much. And Michele, the last word.
Yeah, I think I'll just say that as I'm here representing Physicians for Human Rights, and again, this is an incredible collaboration across all the people here in this virtual room, that, Physicians for Human Rights is a network of clinicians, healthcare providers who care deeply about health, about international human rights. And so please reach out to us. We're only as strong as we are strong together. And we do have networks of physicians, not only in the US, but across the world. So we would love to have you be involved with PHR and with our work on this and other issues. So thank you all. And thanks so much to this wonderful group of women for all working together on this and many other issues.
Wonderful. Thank you all.